you very much. It's really wonderful to be here at such a great international meeting, and I appreciate the invitation. So, as Dr. Abiram said, I'll be talking about the United States outlook on lung cancer screening. And I am here partly on the basis of the Fulbright grant, but I don't have any other disclosures to make. In about 15 minutes, we'll be discussing a little bit about the background of lung cancer screening, and largely going into the results of the National Lung Screening Trial. I'll spend a lot of time on that. Then I'm going to talk about what the U.S. government is indicating we have to do to be appropriate screening centers. And there's going to be a lot of challenges and a lot of issues with implementation that we can also discuss. So lung cancer, as you all know, is the most common cancer killer in the world. In the United States, 173,000 deaths a year. Nothing really even comes close to that, and furthermore, the mortality rate is extremely high. So when you look at the presentation of lung cancer by stage, you see that it's largely in the advanced stages, such as stage 3 and especially stage 4, and there's an inverse relationship with survival, as you can see. So if you present with an advanced stage of lung cancer, you're basically going to die from it. Although, as you can see, the earlier stages have a somewhat better rate of 5-year survival. So looking at those relatively earlier stages of lung cancer, such as stage 1, which means a tumor of less than 5 centimeters in size without nodes or metastatic lesions, if surgery is done, then there's a reasonable chance of survival. Smaller studies have shown that surgery can lead to significant prolongation of lifespan and decrease in mortality. So really, for the screening purposes, we want to focus on picking up cancer early. One of the most important studies that was done for this was started in the 1970s called the Mayo Lung Project, which was an examination of over 9,000 people using chest x-ray screening. They didn't have the CT technology at that point. That study went on for about 8 years, and then it's been followed up for 25 to 30 years to see long-term mortality. Unfortunately, there's no reduction in lung cancer-specific mortality with chest x-ray screening. This has been reconfirmed in long-term follow-up. It's also been reconfirmed in a more recent PLCO trial. Now, one thing that is of note is that as of 1999, they still identified 17% more cancers that were picked up in the Mayo Lung Project screening arm as compared with the control arm. So you ask yourself, well, there was no decrease in lung cancer mortality. What did these extra 17% of lung cancers actually mean? And this raises the concept of overdiagnosis, something we have to worry about when we're doing screening programs. We might pick up lung cancer, but it might be a lung cancer that would not have come to symptoms or killed the patient. Unfortunately, we don't know whether or not, when we find a cancer, it's going to be one of those cancers that does or does not. And this is a continuing challenge for lung cancer screening. So there have been a lot of CT screening trials in Japan. It really kind of started there. In the United States, a number of trials, the largest being the LCAP trial. And as you can see, as you're probably aware, lots of European trials. We heard about the Nelson trial, etc. However, to this point, none of those trials have been able to show a decrease in lung cancer-specific mortality. They might in the future as they're carried out further, but maybe because of the way they were set up, they're not even designed to do so. And really, that's the question that, at least in the United States, the authorities wanted to know. Will this save lives? What kind of cancers do we see with lung cancer screening program? All types. We certainly see the ones that look like obvious cancers, such as you can see in the upper left. And then in the center, we heard a nice talk earlier today about partially solid lesions, or mixed density lesions. And you can see a mixed density lesion there, which is a lung cancer. And what about the one in the lower portion of the image? That's a totally ground glass opacity. This is a lung cancer, but we'll come back to later whether this type of lung cancer, we may need to think a little more as to whether it may be an overdiagnosis. In our program, you know, we pick up small cancers. Here's a 9mm lung cancer that has this pleural tag and we pick up. We never have done this type of thing before a CT scan. We can also do more advanced image follow-up, the 6-month follow-up of this lesion with a 3D volumetric assessment. You can assess growth rate, doubling times, things like that, which have not yet really become a part of the lung cancer screening armamentarium. They are under research, but at this point, linear measurements are predominantly used in both centers. with that background now, I want to talk about the National Lung Screening Trial. This was the trial that led to significant changes in the American outlook on lung cancer screening. It's the most expensive imaging study ever performed in the United States, for sure, and maybe even the world, I don't know. This was a randomized controlled trial of CT versus chest X-ray screening done in over 50,000 individuals. And the entry criteria, very important to know whenever you're doing a screening study, 55 to 74 with at least a 30-pack year smoking history, and either currently smoking or having quit in not more than 15 years before the screen. The structure of the trial was 3 annual screens. One, an initial baseline screen, and then 2 subsequent annual follow-ups, and then clinical follow-up. After that, they stopped the CT screening, they were just doing clinical follow-up, and it was designed to run for about 10 years. They actually, I'm sorry about the way the slides are showing up here. The next line came up, they actually stopped the trial early. Stopped the trial in 2009. Why? Because they were able to show lung cancer mortality decreased by 20% in the screening arm versus the control arm. And not only that, final line, all-cause mortality even decreased as well. So even saved some lives aside from lung cancer deaths. This is the key image, I think, from the paper showing the discrepancy in detection of lung cancer in the low-dose CT arm versus the control arm with chest radiography. And what you can see is that during the early years, there was more of a difference in the slope of these 2 graphs. We picked up more cancers with CT. Out here, they're approaching the same slope. Well, that's because this is only 3 years of screening. So after that, lung cancers that develop are going to be picked up at essentially the same rate in both groups. So it's the difference within this key time frame that tells us about the improvement in mortality with CT screening. How good is CT screening compared to other measures with other screening examinations that we do? So in the ENLIST trial, 320 individuals need to be screened on a regular basis in order to save 1 life from lung cancer death. That compares to mammography. Women aged 50 to 59, you have to screen about 900 women to get 1 saving of life. And in age 60 to 69, with a higher incidence of cancer, you have to screen 1 in about 430. Flexible sigmoidoscopy for colon cancer, about 1 in 800. So the numbers for lung cancer screening look pretty favorable. What about that overdiagnosis question? So it turns out that in the low-dose CT arm, there were 120 more cancers detected than were detected in the chest X-ray arm. And this comprised about 19% of all the cancers that were picked up. It was 79% increase in pickup of so-called bronchoalveolar carcinoma. As you know, there's a new nomenclature system, but almost twice as many of these were picked up in the low-dose arm as in the control arm. So this raises again the question as to the overdiagnosis. We may be picking up cancers that are not eventually going to be killing these individuals. Such that in the trial as it was run, there was more than 1 presumed overdiagnosis cancer picked up for every life saved for lung cancer. So we have to worry about that. And of course, at this point, we don't know when we pick up a lung cancer, is it going to be the one that kills the patient or not? Now, what about the nodule size? So thresholding of where you call a positive CT screen. For the ENLIST study, any nodule, non-calcified nodule, 4 millimeters or more was called a positive screen. So 24% of all the CTs were positive, of all the screening CTs were positive. 96% of those positives were false positives. So we're picking up a lot of things that are not going to be lung cancer. How can we help discriminate between which may be false positive and true positive? Nodules of less than 1 centimeter in size had a less than 1% rate of being cancer, whereas nodules of greater than 1 centimeter in size had a 12% rate. So size is going to be very important. So a study of the ENLIST data shows that as you increase the threshold for calling a positive scan from 4 to 5 to 6 millimeters, you will begin to miss a certain percentage of cancers, either miss them or delay their diagnosis. On the other hand, you will markedly reduce the number of false positive examinations. So for example, at a 6 millimeter threshold, you're going to miss or delay 3% of the cancer diagnoses. but save over 1/3 of the false positives. And modeling in this study suggested that the mortality change from increasing that threshold would not be significant. So the US now is recommending a 6mm size threshold for follow-up. Now this is very important to remember. This is not that you can ignore things that are less than 6mm. The assumption is that the patient is going to be coming every year for a screen. So things that are smaller than 6, you have another chance to look at the next year. Things that are more than 6 are the ones that may need increased follow-up, other examinations. What about cost effectiveness? A very important thing for a population-based assessment of a screening program. So the N-list cost about $52,000 to save 1 year of a patient's life. When you adjust that metric for quality-adjusted life year, a very standardized metric, taking into account the patient's lifestyle, concerns, worries, risks, all that type of thing, it cost $81,000 to save 1 year of a patient's quality-adjusted life. But note that the range was all the way from $52,000 to $186,000, depending upon all the assumptions that go into the model. Is this too expensive? Well, in the US, a metric of approximately $100,000 per quality-adjusted life year is taken as kind of a benchmark of where an intervention may be economically worthwhile in the population. So we're kind of there, but it really depends upon the very nitty-gritty and the details as to whether we're going to be below or above that level. Who were the screens most effective for? Most cost-effective for women, interestingly. For current smokers versus former smokers, that's understandable. For older patients, as an increased risk of cancer, and also the highest risk screenings for other reasons using various metrics. And as the cost of the CT scan itself approaches $500, it's no longer cost effective. So we have to do this at a low rate of charge and a low rate of reimbursement, which brings all kinds of other issues. So what are the N-list benefits versus harms? In a nutshell, the benefits were for every 1,000-person screened, you'll save 3 to 4 lives from lung cancer. You'll also save maybe another life as well. And all these patients are in smoking cessation programs. It's required to be accredited screening program in smoking cessation, so there might be improvement there as well. What are the drawbacks? All the false positives, 375 out of 1,000 patients screened. More biopsies, more surgical procedures, more complications from surgical procedures, and then we have the issue of radiation, possible radiation association with causing cancer that still remains debated. Oh, and those criteria, by the way, are the 4mm size threshold. So, with all of this data, based largely on the N-list, not completely, the United States government looked at this and said, we are going to recommend screening in this following group. Asymptomatic patients, very crucial. For a screening program, you have to be asymptomatic. You can't have signs or symptoms of lung cancer or even known other systemic malignancy. They said age 55 to 80. If you remember, the upper limit was 74 for the N-list trial itself, but based on modeling, they took a bold step and went and said, we can actually support this up to age 80. As you know, older screenings have more incidence of lung cancer. 30 pack year smoking history, quit smoking less than 15 years ago if they did quit, no other health problem potentially affecting life expectancy. And they gave it a so-called B grade for private insurance coverage under the Affordable Care Act. You've heard of the Affordable Care Act, that's called Obamacare. So private insurance companies now have to cover screening for people who fall into this category. However, we have another system in the US called Medicare. And Medicare is a governmental payment system for individuals 65 and older. They were much more reticent to do this. They said there wasn't enough data on the older individuals from the N-list, etc. So finally, after a massive effort, they did agree to cover it under a draft protocol. The final is going to be coming out probably next week, up to age 74 only. Whereas the median age of lung cancer is 70, so we're going to miss a lot of individuals here. What other requirements are there going to be a screening program? You must screen the appropriate population. You have to have consultation regarding risks and benefits. You have to have a smoking cessation program. You have to have a way to get health care provided for individuals who come in and have an abnormal result and may not have a health care provider. You also have to follow a whole array of requirements for CT, technical performance, professional performance, reporting, data management, etc. For radiologists, you have to have experience reading chest CTs, you have to be an approved center, either through the ACR or through another mechanism which you may be participating in. You have to send all data to a governmental approved registry, and they have a lot of specifics on their website. For radiologists, we need to assess nodules thoroughly, location, size, meaning the average of the bidimensional measurements. 3D is not required, or volumetric are not required. What type of attenuation? Obviously, part solid nodules are very important, or the opacity, the margins of the lesion must compare, as we heard earlier, to all the prior scans and have a structured reporting system. So this is going to present a lot of challenges for us to ramp this up to a population-based approach, both in nodule detection and, more significantly, in nodule comparisons. You're going to have all these CTs, you're comparing 10 nodules on 5 subsequent CT scans. We need help with that. We need non-human help with that, and these tools need to be developed. We had a brief example of the lung Rads earlier. Lung Rads meeting from BiRads, now we're going to have lung Rads. This is the whole chart, and I'm obviously not going through it, but it's basically the same kind of structure, grade 0 through 4, and various modifiers. You can see the different colors pertain to solid, part solid, and non-solid lesions with various recommended follow-ups. A lot of structure here, a lot of regimentation. For the CT itself, it needs to be at least a 16-slice scanner with thin slices, and the dose has to be regulated by body size such that it's no more than 3 milligrays. So, very rapid go-through of that. We have a lot of challenges to implementing this. Even designing a program according to all these guidelines, getting institutional buy-in, because it's not just the radiologist who's doing this. You really need a team. You need pulmonologists, you need primary care providers, you need administrative work. Will this be supported? Will there be enough money here with the financials? We don't even have a formal designation in our payment system in the US yet for a screening lung cancer CT. Will we, as the radiologists, be paid appropriately for all the extra work that we're going to be doing? Will insurers cover all of the additional care now, which is going to be recommended based on the results of the screening study, the vast majority of which show false positive results? And how applicable will the program be across a national database, national substrate? You know, NLIST was done at 33 centers or 32 centers. 3/4 of them were academic medical centers. When you take this out now to the community, rural areas, etc., where you might not have subspecialty chest radiologists, how good will the results be? How can we focus screening on the highest risk patients? We need to keep this as a cost-effective way, and as you see, we're kind of borderline with some of the cost estimates. How can we improve discrimination between benign and malignant nodules? How can we reduce overdiagnosis? How can we even learn what may be an overdiagnosis? What can tell us early signs of an aggressive cancer that needs to be jumped on quicker? Do we need biomarkers? There is an extensive array of biomarkers collected in the NLIST trial, blood and sputum, urine, which research is undergoing and will continue. And finally, what about all the potential harms of screening? There are harms that we know about and there are harms we don't know about, and only as something develops in a larger state will we be able to get a better handle on that. So that's a very quick run-through of where we stand in the United States, and so now we're going to shift to see where the Israeli thoughts about this process are. Thank you very much.